After penetrating keratoplasty, when the patient presents with failed graft with a good surface and anterior segment, dissect is a viable alternate option. In routine dissect, the popular TACO technique and unfolding is always easy and smooth. But dissect in failed PK has different problems during surgery, like difficulty in donor insertion, donor unfolding, donor centration, shallow anterior chamber due to low scleral rigidity, and donor dislocation is higher. This video demonstrates some tips and tricks during surgery to achieve a better result in these cases. Number 1. Determination of donor size. Overall corneal diameter, previous graft diameter, and a preoperative anterior segment OCT is a must. Normally, the teaching is use dissect donor tissue with a diameter less than or equal to the previous PK graft. If the OCT picture shows smooth posterior surface and the previous graft is around 8 mm, use same size donor tissue. With smooth posterior surface in OCT with a 7 or 7.5 mm previous graft, 1 mm larger donor tissue can be taken, and it is preferable. But if there is a posterior ridge detected by OCT, irrespective of graft size, then a smaller donor is preferable. Otherwise, dislocation may occur. Even with smaller graft, if the donor edge crosses the ridge, there is also a chance of donor dislocation. Number 2. With or without Descemet stripping. It is always better to strip off the Descemets and always coat the Descemets just inside the host graft junction. Otherwise, there may be chance of wound dehiscence. At times, Descemet's membrane is thick, irregular and pigmented, which may be responsible for higher donor dislocation. Even it is attached, late interface opacification remains a problem. Number 3. Removing the edematous epithelium. It is required for better visibility. A tricky situation. Always remove epithelium from inside the host graft junction. Do not remove the suture during surgery when epithelium is removed. Again, there will be chance of wound dehiscence. In contrast, dissect in plain cases, one can remove the edematous epithelium freely till the limbus is reached. Number 4. Insertion of TACO. This is again a tricky situation. Because of previous PK, the scleral rigidity is lower in most of the cases, so the globe tends to collapse. Furthermore, the posterior ridge at the host graft junction may interfere with full entry of TACO into the anterior chamber. This could be solved by gentle manipulation after BSS injection and tapping of the tissue from the surface. Number 5. Unfolding of the donor tissue. It is not easy as in routine dissect cases. BSS and air from the side ports do not help all the time. Some cases it may open halfway. External manipulation is then required and further air injection helps in complete unfolding. Furthermore, injected air tends to escape through the main and side ports because of low scleral rigidity. Suturing the main incision is very helpful, but it may not be sufficient at times. Still, the air tends to come out. Suturing the side port and a jet of BSS is then required to unfold the tissue. Sometimes a little manipulation from the side port is all that required. Number 6. Centration of donor tissue. In routine dissect cases, gentle external massage with a round instrument brings the graft at the center with uniform golden ring all around. In post-PK dissect for smaller or same size graft with smooth posterior surface, this is not a problem. Gentle massage till the appearance of the uniform golden ring. It is difficult with larger graft or when there is a posterior ridge. External manipulation is best done with a side port blade, which also creates vent to release interface fluid. When the unfolded donor is shifted to one side, a 30 gauge reverse bent needle may be used through the main port to pull the tissue gently towards the center. Then gentle massage. Even if it doesn't help, external manipulation by side port blade and finally with a 30 gauge straight needle may be used for perfect centering. Gentle massage from external surface is still important to remove any folds created during this manipulation. Number 7. More air tamponade. It may be for 20 minutes rather than conventional 10 minutes. And only a little air is released at the end of surgery. And when the epithelium is removed, a bandage contact lens is given. These are some of the cases with good anatomical and surgical outcomes. In summary, the key points for success for dissect in post-PK cases are anterior segment OCT, donor size determination, Descemet stripping, do not cross the host graft junction, care during taco insertion, close the incision ports if required, unfolding of donor tissue with air or BSS, careful and perfect centering of the donor tissue, and air tamponade for 20 minutes. Thank you for your kind attention.